The knee, we can go through the knee because it is a relatively easy target. So supine position, flex the knee, because when you do lateral, your other knee will come in your way. One of the easy things just to go with the needle, like a finder needle to the target. So you want to stabilize with the
That one right here.
Just AB. So it's a little bit like externally rotated because you're gonna do your incision in the medial side. So you want just a good exposure. And especially for this nerve, I mean, you can put it in general. I mean, the response is here. It's like it's just anatomical target. It's not.
You know what it.
Okay, do X-ray. Just oblique. To go down a little bit, oblique toward you. So a little bit more. A little bit more.
I'm trying to treat the patella in the center.
Yeah. Okay. So this is here like a decent. So let's say I will put my lead. I can do the four contact. It's considered as like there is no tines here, but you think just this is the permanent implant. Is the tines. So put everything. You can plan. See? So, I mean, this is not the perfect, but as a trajectory, you see where's my needle? So my needle is, you see the contacts, the microchip, the tines will be here. My first marker bend, second marker bend, to the area here where I want my first incisions. So I may be a little bit farther to give myself ability to, manipulate the needle, so close to the first marker bend. So this is a decent here incision for my entry point. So I will just take this here with a marker in the skin, with local. What usually I do, especially if I'm comfortable with the needle, everything, I will do my incision first. When I started with kind of a big incisions because I'm still not comfortable. And then I started to be like more comfortable, as I go smaller and smaller and smaller. And then I started to go bigger again. Now, as I started again, because I feel like you struggle a lot to save maybe a centimeter or half a centimeter incision. So I started to be a little bit of bigger incisions, not like a huge incision, like 2-3 centimeters is decent. Get to the tissues, and once I get to the tissues, usually I take a one suture first. So I take a suture to the tissue, be sure I have got like a fascia down there. I use Ethibond, 2O Ethibond, and do like 2 or 3 knots in the tissues down there. And then after that, I will put my needle in the middle of the suture. So I take a sutures down like a 3, and then I have the 2 ends of the suture, and then I put my needle in the middle between the 2 sutures. And then I go to the target. So once I'm done, everything is in, so my suture is be already around the lead, and I will just knot it. This will save me a little time than after I put my lead and try to get around the tissues, taking the suture down there. So let me, let's say for example, I don't have any surgical. No.
What do you need?
Instrument. Yeah, okay.
Markers?
No, I cannot make incision here.
Oh, no.
Okay, so let's pretend you're gonna feel the tibia here. So I don't want to do an incision around the tibia, just a little bit more posterior. When you have like a muscle here, my entry point, X-ray please. So this is a decent entry point. You can put another needle, like a finder needle. You don't have to do
Put
that.
the red one up there for you if you do want to do that.
Maybe I'll go for the big one. Are you okay if I put the big one, or I
I
miss
care.
up the?
No, you're fine.
X-ray. A bit down. So here's like a decent target, but I didn't see lateral. So ideally we want to go to lateral. We want to see it like around the middle third, just to save movement. We can start here and then, just to save X-ray exposure. So I will go to my target. See? So too much lateral. And the plastic feeling is different. To go back. And we have a shorter needle or longer needle, and the rep will give you the needles. And this is a codeine needle, so it's sharp. The directional ability, it's very good. You just twist it right and left, it will change the direction a lot, but just be careful. It's cutting, it's really cutting. Close. You can touch the bone. You can touch the bone. Did they have a bone here, or does the mother have a bone? Straight. Yeah, switch the outside. Simply you want to make it across the flare. Okay. So I touched the leached bone here. Excellent. It's too much. Excellent. Another question is, do you want your needle go all the way to the target, or maybe shy of the target, then advance the lead beyond it? It is safer just, to have the needle maybe tip away from the target a little bit and then try to move the lead, but it's not that easy because it's not like a good tissue plane, and the lead also is not that strong that allow you to go in the tissues. So the easiest is to have the tip of the needle where the target is, and then put your arm. You can use the lead blank to create a little bit of a bath, and then put the lead. But the lead blankets, be careful, it can be traumatic, and also it doesn't have any direction ability. So it can go whenever it will go. So at that stage, I will go to lateral X-ray.
So you like to go right to the spot, right to the...
Close to the spot, then I will go lateral. Because now I don't have like an idea where I'm like, maybe I will do here, and I will find myself too much posterior, close to the blood vessel, like with the popliteal, or too much anterior. So I will go lateral early. You can have a feeling. Sometimes you feel that you are too much anterior, too much posterior. But again, patients are like sometimes huge knees. Sometimes they have already metal there, so it's not easy to see. So I will try to get good lateral. See how I'm posterior? More, a little bit more, a little bit more. So I'm too much posterior.
Yeah.
So the tip of the needle, let's say I want my lead is like anterior third, middle third, posterior third. I want my needle in the middle third, a little bit more anterior, or the infrapatellar. So I'm too much posterior. So I have to go really back. I felt the bone, actually. Okay. And more anterior. So here like a middle third. So I'm comfortable with the. I feel the bone, and even I touch the needle. Excuse me. Touching X-ray. So this is a very decent from the like a middle third, and then I will check back again anterior. So I'm across the flare there. You don't have to be really on top of the bone if you are a little bit anterior, because ideally this location with the inferior medial genicular, but the infrapatellar branch is more anterior. So if it is a little bit more anterior across the flare of the tibia, this will be actually maybe better. So then afterward, we just remove the stylet. You can use the lead blank to give you a little bit of bath. See? So you're decent here of the lead. And then the rep will let you know when when your tines will be. So he will put like a marker. Adam, can you explain this to them?
So for the implants, we want to make sure the
Using
contacts.
the long needle.
Yeah. So we're making sure that the contacts are coming out of the needle. If you guys would prefer to do interrupt testing during the procedures, so we want to make sure the contacts are coming out of the introducer. But once we go too far and the tines start to deploy, it's kind of getting to the point where no return. We won't be able to retract that lead if we're not happy with where replacement is, and we have to take the needle and the lead out and start all over again. So we typically will put a mark with the scrub tech. It's approximately about right here in the lead, you know, almost in between the two marker bands, and that kind of shows your point of no return
Those the tines.
before the tines deploy. Correct.
So you see the tip. So this is they give you the direction of the tip. So it can help you. Maybe you want to direct more anterior, more posterior. So especially with the infrapatellar, I would try more anterior. So maybe it will exit anteriorly, but I mean it's not a must because it's not like really directional. So you're gonna feel the resistance. I'm off. So I try to exit there. So this is very acceptable. Yeah. So I'm still inside here. Once the marker that we did it in the lead, that means that the tines are out. X3. So almost all the four contacts is out there. You may want to check lateral, especially with the permanent implant, to double check that we're still there, it didn't move, that we are around like the middle third of the tibia. It's not like a straight lateral, but it's from this on acceptable. Thank you, sir. Thank you, sir. It's like the middle third. It's very acceptable.
I take that.
Yeah, it's like a perfect.
Yeah.
So I'm happy with this. So the finder needle now doesn't have a job.
Time to go home, find a needle.
And then get again. You can do it under pulsed life if you want to be sure that stay there. But usually it's just stay within a few millimeters. So you don't have to expose yourself to X-ray like unnecessarily. So just simply like hold it, and then I'll back it.
Yeah, sometimes with the tissue it needs a little twist or a little
Yeah, so I've had trouble twice where the tine like doesn't fully deploy, and I'm trying to back out my needle, and it just keeps pulling the lead, and there's no. So do you try and twist as you're coming out, or like how do you defeat that?
I mean, you can twist or just push it a little bit farther. Just play with it. Sometimes it's very superficial. You can push your hand. Like sometimes I just put my hand here, or a nurse or assistant to keep it stable, especially for superficial target like this one on posterior tibial, and get it out.
Yeah, I think
To take a picture, you see it moved.
Twistage.
Yeah, a little twisted I think will help. So
Start there, perfect. And all the time, having your hand in something, not in the air, you have more sensitivity, especially with a lot of coffee.
You don't have to be like more lateral.
More anterior, Dr. Khan.
You don't have to be like. This is a good position, or you need it to be a little bit more
Lateral.
Lateral.
The inferior genicular nerves,
More lateral.
a little bit like here,
Yeah.
but they curve all the way across.
So this is better for
Especially the
infrapatellar.
exactly. The infrapatellar branch, especially, it's coming more cranial and more anterior.
Yeah.
So like around here, curved around. So by this, it will give you the
Good
most
curve.
of them.
yeah, the pictures from the textbook show how he was explaining it, but this is going to cover it.
Yeah.
So, and then you remember this stylet is not the receiver, so you have to take it out. Okay, and then you have to put, now without the receiver stylet, this is not functioning. So you have to put the receiver stylet, which is a very tiny thing. You see how tiny it is? And then to put it inside here sometimes it's challenging, so sometimes we make a cut you can have a scissor, cut this end with like an angle. So if you cut it an angle, this will increase the surface area of the lumen itself. Sometimes you can have like a marker pen. You put the marker pen in. If you like put the marker, you're gonna see it better. I give this step to the fellows usually. They have much younger eyes, or so. And don't if you put it in the space, sometimes you are fighting like so. Put it on something like stable, and hold it very close to each other. And good luck.
Good luck.
And
He forgot his loops at home today.
yeah.
Told him to bring them.
Sometimes you get a home run first time, so you get it in. So another tip: make it slow and easy. I will take this off because this doesn't have function now. It's just to identify which proximal, which like distal. And if you rush it, you will kink it. So make it slowly. Slowly, you can talk with your fellow about something fun. Scrub nurse, anything like fun. Take a break. If you have an assistant and you really want to be like efficient, while you're doing that, I mean, you can do the
Start the
second
tunnel.
incision. Your assistant do the second incision, do local, and start the incision while you're doing that. You can like work at the same time. And as you advance it, once this receiver will reach to the microchip, you're gonna feel a little bit of more resistance. And be sure it's all the way in. Usually just 1 inch.
Usually
again,
approximately an inch, but you'll feel a hard stop when you get to the bottom. And also depends on how much you cut off if you do that angle, which
Yeah, if you cut a lot or less. I think I have more resistance now. It's going easy. Easy, easy. If you kink it, there's another one. I think it's all the way in. Okay. Then after that, planning the second incision, you see the first marker bend, second marker bend. So here you have the incision. I already suture here, one suture down there, and then your second marker bend. Anything here, anywhere across all this area, you want to do your second incisions. Again, the tibia here, so I make the second incision down there. All this is unnecessary, so I will cut, make a just simple knot to keep the receiver. I need to keep the receiver inside. So simple. You can put 2 mosquitoes and just tie them off to be sure. You then move the lead. You can take an X-ray, double check. You can ask the assistant to put his hand here, especially with this superficial location to prevent any movement. And again, there's a tine, so you may pull it back a millimeter or so to make the tines to hook to the tissue. You make this one, you make the second incision around here. Ideally, the second incision, you want it a little bit bigger than the first one, because here, what are you gonna do with the coil? You AC bonds. Again, they recommend doing like a couple of loops like that. You cut here, okay, and then you're gonna take at least 2 sutures to keep it. So 1 suture here, 1 suture there, okay, and then you suture to the tissues, down to the tissues. So you're gonna open the second incision, dissect. See, you see a facial layer, and then suture it down as a like anchor. The area from the first to the second one, be sure it's straight. It's not a huge deal if a little bit of like landing. This is okay. A little bit is fine, but ideally you want it straight and like at 2 centimeter, 4 centimeter from the skin, because this is here, the area here. This is the main area where the patient will put the wearable. But again, for the superficial location like this, he can use the wearable anywhere here. He can still send the signal and capture it. Wash, close,
As far as the incision, are you using skin glue or are you just series strips or
Oh,
are you also suturing?
Yeah, I still suture, do like a subcutaneous layers, like I use
Okay.
2O Vicryl or BDS.
Okay.
Skin I use a 3 monocryl.
Okay.
Usually, glue, stir strip, whatever your routine you use. One point that we don't start the stimulation. So the patient have two wounds, and if you want to start the stimulation, the patient will use the wearable over the wound. So it's not good to put like the wearable, the external transmitter, over a fresh wound, and the patient will use it. So I will cover them and not use the stimulator. You see the wearable?
Mhm.
So you put it over a fresh wound. It's not that good. So I will just give the patient antibiotics, some pain medication. Don't use them for a week until I see them.
If they're compliant.
Yeah, depends on your patient population. Take a look. If the wound looks okay for you in a week or 10 days or so, they can start the stimulation. I mean, this is the basic. We can go to other targets.